the Faculty of Medicine, Civil Hospital, Mahidol University. He holds a diploma of the Thai Subspecialty Board of Diagnostic Neuroradiology. He was a research fellow in advanced neuroradiology at MGH, Harvard Medical School, a few years ago. Today, Professor Shannon will be presenting a lecture titled Clinical Application and MR Research of Advanced Diffusion Imaging in Neurological Conditions. Please welcome Professor Shannon.
Good morning, everyone. So, I will thank the organizer for inviting me for this talk. And I am Shannon Yamsompat. I'm working as a neuroradiologist. So, some of my presentation will be the real patient in food situation in Thailand. Okay. So let's start with this is overview of my talk. I will talk about basic diffusion imaging and clinical application, and also some of the diffusion models that might be used in clinic and also for research, and also I will touch about the brain connectivity and phototractography. So this is the work. So for MRI, so we want to use MRI to characterize not only macro structure, but also move to the meso structure. And yes, now we can characterize some of macro structure like the myelin sheath and also the intra or extraoptimal space at the level of microscopy. There's a micron level of imaging. So this is basic. This is very basic diffusion equation. So this is my one of the equation that I remember when I was studying in physics. So this is central channel equation. So the signal intensity of diffusion, it depends on the B0 and also B value and ADC. So ADC is actually the slope of the signal decay. It depends on the B value you use of the scan. So it started with B0 acquisition, and depends on the B value you use. In clinic, we normally use about 1K or sometimes 800 to calculate the ADC and also DWI image. So most of the diffusion imaging in clinic nicely demonstrate the white matter pathology. So in research, some diffusion model can evaluate and demonstrate some white matter parameter like axonal parameter, and hopefully we can do diffusion to evaluate gray matter. So, but in clinic, still some limitation because maybe resolution and imaging technique, but hopefully we can use that in clinic. So this is the factor affect water diffusivity. So we have cellularity, viscosity, permeability, and also histology architecture that affect water diffusivity. This is how diffusion imaging appear. And so I will talk some of the critical applications that have been used in real life in clinic and my inpatient. So let me show some of those applications. This is very common. So we have resistive diffusion at the right MCT territory involving the coronary radiator and frontal and parietal white matter. This is because the patient has like a occlusion at the right MCA. So this is quite common application of diffusion imaging in clinic. So this acute right MCA infarction. So this patient came to the hospital with like a transient memory loss. So we see the resident diffusion dot and the hippocampi with the corresponding low ADC. This is not artifact. This is the real lesion. So actually, this lesion is not accurately seen over the axial image because the scanner you can see may be very old. So our resident tried to demonstrate in the other at the plane like a coronal view to confirm that the lesion is true. Okay, we call this transient global amnesia. So this patient came to the hospital with progressively cognitive decline. So you can see quite a little bit high signal intensity over the cortex and bilateral ventral nucleus with also low ADC in this region and also along the cornice with resident diffusion. So the flare image is just subtle. So, but if we see the visual image every day, maybe 10 or 20 cases every day, you can realize that oh, this is true lesion. It's not normal. So this is peripheral Jakob disease or CJD. So the radiologists have to recognize the abnormality compared to the normal. So in this patient, he got a surgery a few years ago and have like a clinically ruled out different disease. So we see the lesion at the middle ear, and the lesion there is no sort of enhancement of the lesion, but just peripheral enhancement. But the MRI image show a focal resident diffusion dot in the surgical bed because the patient was surgery a few years ago. So this is characteristic of cholesteatoma. Cholesteatoma is like colon inflammation from a mass lesion and has characteristic of resident diffusion. So we use DMRI to confirm the diagnosis. So this is the patient came to the hospital with fever and also headache and some weakness. So you can see the thin rim-enhancing lesion at the inferior frontal parietal region with resident diffusion over the DWI image. So this is characteristic for brain abscess. Thin rim enhancement with central resident diffusion. We don't see resident diffusion like this with a tumor or other condition. So we use ADC value to follow up the patient after treatment. So if the ADC getting increased, the patient can improve. But if the ADC have reappearing of low value, so you have to look at the patient. Maybe the patient has recurrences for the abscess. So other than that, you can see IFA. If you calculate the SF map over this patient with abscess, you can see higher FA over the cavity of the abscess, but not seen this thing over the tumor like glioblastoma or metastasis. It has a different mechanism. So this patient came to the hospital with fever and drowsiness. So you can see fluid collection along the interhemispheric fissure without obvious enhancement or resident diffusion. So yeah, the patient has fever. So this is the nature of the disease. If we capture the imaging at the early stage of admission, so you can see the subdural fusion. It's not the abscess yet. It's like an evolution of disease. So if the patient came to the hospital late or disease or suffer from disease location, you can see resident diffusion of the effusion. So it turns to be it turns to be subdural ependyma. So diffusion imaging can be used to characterize the infectious process and progression. In this case, it is restricted diffusion here over the CPU ankle region. So, but not enhancement. I didn't grab the enhancing image, but it's very typical for epidermolysis to have the CPU ankle mass with restricted diffusion. This is one of the clinical applications. So this patient suffer from left visual loss for a while. So you can see there is T2 hyperintensity at the left optical nerve with maybe high signal intensity over the diffusion image, but ADC map is sort of like a artifact, right? So we also require the in-plane high resolution image over the orbit area. This is a thin slice and like a delicate protocol for optical nerve with DWI. You can see clearer. So segmental oriented diffusion of the optical nerve at the area of 2 intensity. So we can characterize the phase of the visual loss, right? This is active lesion of acute optic neuritis. I will try to characterize the optic nerve maybe several years with other diffusion metrics, but it's still hard, because there are a lot of artifacts over the orbit. But hopefully we can use other MR metrics. Okay. This patient came to the hospital with acute weakness, and the doctor was suspicious of acute spinal cord infarct or acute myelitis. You can see we have seen the T2 hyperintensity in the spinal cord, but it's sort of subtle, right? Is it artifact or not? We don't know. We have to confirm at the axial view. On axial view, we see T2 hyperintensity over the anterior horn of the spinal cord bilaterally. So on the image, is it common to have the image when the patient has been suspicious of acute spinal cord infarction? So at that time, we scan diffusion image on the cervical view as well as axial view. You can see restricted diffusion on the area of hyperintensity, and that this has been confirmed on axial view. So for beginner, there may be a question, oh, this is artifact or true lesion? But if you see this patient, this kind of patient, more often you can realize that this lesion is true lesion. If you compare it with another level of spinal cord, this is the normal level of spinal cord. You can compare. This is normal. This is normal. Okay. These things have to be set up on site and at the MRI, right? Because you cannot think about setting up this thing properly without preparing, right? Because the patient is on the scanner. Yeah. Okay. You have to prepare this. In this case, it's quite a little bit subtle. The patient came to the hospital with ophthalmoplegia. So you see vision? Yeah, maybe this, right? It's like a subtle T2 hyperintensity at the dorsal of the lower midbrain with maybe restricted diffusion of the lesion. So this is a true lesion. It is internuclear ophthalmoplegia. If you look at the image closely, this true lesion is sort of asymmetrical DWI hyperintensity. Okay, body lesion. This is more obvious. You can see restricted diffusion at the left side of the interpeduncula area. So this is acute lung infarction. For this case, so the patient came to the hospital with just like non-specific symptom, headache, dizzy, something. So the patient get a scan. He got the scan, and the doctor asked me that, asked my resident first, that this is lesion or not, because you didn't write down the report about this lesion. Okay, you see the lesion here, but not on flare, right? Just only on BW, right? So if you look at this closely, it's like a kind of pulmonary hyperintensity, but very subtle. So this is lesion. You think this is lesion? You think this is not lesion? Okay, just a few of you have you response. So yeah, we see this maybe every day. So this is because this is normal. It's actually normal. So this is the interpedicular region. So the second intensity of we call the IPR significantly positively correlated with age, but not with gender. So the ADC value of the IPR is significantly changed in aging, and ADC has not affected on the signal of the IPR on the WI. So sometimes you might want to measure the ADC value in difficult case, right? So this is because this is so the decassation of the superior cellular peduncle may be included in the IPR and may be effects at the skin activation. So it is entirely normal. Yeah, entirely normal. So yeah, I was asked for the lesion around the difficult area for several times. So this is the imaging technique that can improve the visibility, the detection of the lesion over the brain area. So you can see in the clinical value, you can see rested diffusion. This is okay, right? Because you can see this lesion on your eye directly. But in difficult case that I mentioned, you can adjust the B value, maybe 2K or 3K, depends on your scanner. And sometimes you might want to scan with the thinner size, maybe 2 or 3 millimeter. Yeah. So if you increase the B value more, maybe 3K, 5K, the lesion increasingly popping up, but the background and the background, the signal of the background has been dropped, and the signal to noise increased. Right? Overall it works for overall image, but the lesion has been highlighted. Very nice. Okay. So this is the talk. This was Naily's talk by Susie yesterday. That's why that's how we analyze the data with the different gradient, how we use it as a research also. So for conventional system, we use 40 to 60 gradient system, right? But for research like one MRI research using diffusion imaging, you might want increase more gradient to characterize the pathology of the brain, like advanced diffusion model. So for the clinical scan nowadays, you can increase more with the B value over the high regime. Yeah, for using it in clinic, and also for advanced diffusion calculation, right? You may want to characterize the brain with axonal imaging something. Yeah. So this is the clinical scan. We didn't use the research mode. This is just came with the scanner. So this is 10K. This is 75K B value. So the image still can be interpreted by our eye. So this is the real patient got a scan outside our hospital, E1.5T, it's actually negative, but the patient has like a fever and was sent again to another hospital. So they use 1.5T similarly, but you can see, is there any lesion? The patient was sent following out the symptom of encephalitis. You see lesion? Here, right? Here, very subtle. Because we didn't see this lesion on the first scan, but obviously see on the second scan with different hospital. It didn't mean that the first hospital has a poor scanner, but I think this patient getting worse. That's why they get a scan for follow-up, so the patient, so the lesion pop up. Okay, because it 1.5. So yeah, this lesion is very subtle. So the patient have been diagnosed encephalitis. So this is another case. Has been sent to the hospital with fever and seizure. Yeah, was sent to rule out the encephalitis. You can see the state diffusion at the hippocampus. So one day before, the patient have scanned with 1.5, but you cannot see the lesion. So higher field magnet may be better for evaluate this kind of lesion. This is thin slice, this 3 millimeter thickness, yeah, acute encephalitis. So I'm going to talk about limitation artifact with clinical scanner. With clinical DWI, you can see artifacts over the temporal and also inferior frontal because of the airborne interface of a large sinus in the patient. So it might be worse like this. If the patient has the dental material, okay, this is DWI, but you cannot evaluate anything. Okay. How we cope with this situation on site. So I just tell that because the patient was sent to rule out acute cerebral infarction, so we just have the scan. We just have the DWI scan. It enough, right? So I just tell the technician on site that just use this technique. If you have, it's much better, right? This one can evaluate. I mean, a large infarct can exclude large infarct for doctor. Okay. Anyone guess what is this one on the clinical scan? This is the non-EPI. I just tell the technician that just do non-EPI whatever you have. One of those was TSE. Just do it. 10 years ago I tried to use this technique on the clinical scan 10 years ago. So it's really very slow. Within 10 more minutes, you guys like that's not the commercial available yet. But now it is also on the 1.5. Yeah. Just 5 minutes. It's okay. It's okay for clinical use. And the often question I got from clinician on site or from my resident, the DNI was worse, was bad, and patient getting motion. I just check the contrast already. So, but just check over the DNI image is bad. You cannot evaluate that. How we do this with the DNI. So I just tell them, you can scan that again. So the resident asked me that. You still can evaluate the diffusion imaging after contrast study? I just tell them that, you can. I will show you. So this is the pre-contrast imaging of the acute stroke patient. You can see the state diffusion, right? So the lack of significant difference between the signal to noise and contrast to noise ratio of before and after administration of contrast agent indicate the feasibility of full contrast. Okay, just scan it. So The thing is that the value of the ADC change after contrast median injection, but just 2 or 3%. They change systematically. So we still can diagnose patient correctly. It's okay to interpret the diffusion imaging after contrast injection in clinic. So I will move to the research section. So some of those have been conducted in Thailand and some of them have been conducted at NGH. So diffusion tensor imaging, let's start with this. So the acquisition comprising at least one V0 value at the fixed diffusion time, roughly not exceeding 1K or 1500. And this is the output, the main output of the DWI. So it's basically characterize the anisotropy diffusion. So we have to use at least 6 direction diffusion. So this is the output, MD, AD, and RD and FA. So this is one of my first research conducted in Thailand more than 10 years ago. When we try to learn about diffusion imaging, I use DTI to track the aqueous fasciculus in Thai language, in Thai speaker, so in normal. So I want to lateralize the dominant hemisphere. At that time, we also use fMRI to select, to localize the seeding area. For this case, we characterize, we show the roca and verticate, and we just do tectography from this seeding. So yeah, the result is okay. We can lateralize the dominant hemisphere from this technique. So this is what I analyze the optic radiation in advanced glaucoma patients. So we track the optic radiation and we compare with the severity of the glaucoma. So it's highly correlated. So at that time, I started to analyze the optic nerve directly in this project, but technically difficult. So we just report the abnormality over the matter, but not optic nerve directly. So we also analyze the tensor over the Alzheimer's disease. At that time, I analyzed the posterior cingulate gyrus. This is believed to be the early area of the Alzheimer's disease involvement. So the tensor show differences between a patient and control at that time. So I also analyzed phonics in Alzheimer's disease and also the hydrocephalus. The hydrocephalus patient just has a dilated ventricle. So sometimes the clinical perspective is difficult to differentiate between Alzheimer's and hydrocephalus. So we show the different damage of the phonics because the hydrocephalus has just like direct pressure effect over the fiber, and the AD patient have like a neurodegeneration resulting neural loss in hippocampus and have axonal degeneration along the phonic. So entirely different mechanism of the tensor abnormality, right? Okay. This is a very basic imaging processing of the fiber tract that we have been used. So first is deterministic, second is probabilistic topography. Simple. So the basic of the deterministic of stimuli is relying on the propagation of water from voxel to voxel. So and we use FA and angle threshold to like a rule how the water propagates, right? So another way is probabilistic tectography. You calculate all probabilities all over the voxel you want and just choose what you want for that situation. So this is how tumor involves the tract and how tensor change along the tumor. The first one is just deviated. The second one is like a edematous area that involves the tract. The third one is tumor infiltrated along the tract. The fourth one is dangerous, so it destroys the tract directly. You see the case, the clinical case that has a carcinoma at the supratemporal gyrus, just below the A1, the Herschel gyrus. So you can see the carcinoma just entering to the tract. So this helps a lot for clinician, for planning. This is carcinoma. So this is a tumor, low-grade tumor just deviated the corticosteroid tract. This is ganglioma. Okay. In this case, you can see the tumor infiltrate over the tract, corticosteroid tract. So this is low-grade glioma. This is used for surgical planning. So for this case, you can see deviation of the CST by the tumor posteriorly. This is because the primary cancer that have a metastasis to the brain. So this is the tumor at the cellular fossa and complex the optic chiasm superiorly. You cannot identify the optic chiasm clearly because the tumor is so large. So the question is that the patient should be getting improved after surgery or not, or any information for doctor to tell the patient that after surgery you might not improve a lot. What is the information or clinical biomarker that the doctor can have? Can tell the patient. So we cannot analyze the optic chiasm directly. So we just analyze the white matter fiber. It's correlated very well with the degree of the patient and also the results of the surgery at that time. Another way to analyze the tensor is a tract-based spatial statistic analysis. So it just like a scrutinize the tract over the whole brain compared to the template that you have. So in this case, in this study, we analyze the Alzheimer's disease and major depressive disorder and see how different of those kind of patients. So we see a smaller FA value over the frontal and the area of the corpusculosis using TBSA. So let's move to kurtosis. So the kurtosis acquisition comprising of these two non-zero B value at the fixed time. So it's different from tensor because the kurtosis analyze and describe the degree of non-Gaussian measure. So I think using B value not exceeding roughly 2500 to 3K. So the main quantity map is not only kurtosis, also the original tensor. So it's highly sensitive to multiple factors of microstructural property compared to the original tensor. You can see the signal decay is not linear, right? Because it's not Gaussian. So this is the decay, right? So at that time, almost 10 years ago, we tried to setting up a protocol for research using multiple B value. The first time for our hospital. With help from Dr. Hua from Beijing University. Yeah, he nicely set up our protocol for using in research at the first time. So this is the protocol. 10 years ago, you can see it's still good, right? At that time, it's just research. Yeah, we learned at that time about research for diffusion, and we can demonstrate the abnormality over the CST in the patient with hydrocephalus that might be related with the results of the treatment. Okay, then goes the WMGI, white matter tract. It actually based on the kurtosis model, but further characterize some of the output like axonal water fraction, intra and extra axonal diffusivity. It's nicely developed by Fishman and the group. And this is my work using this parameter over the MS patient. So at that time, I analyzed the optic radiation in multiple sclerosis. I compare with the retina dimming using the OCT data. Using OCT data, so So there is a nice correlation with the thinning, with the severity of the retina compared to the axonal parameter like axonal water friction. You can see a nice correlation. So the patient has retina damage and also the axonal damage even not normal appearing white matter. So next I'm gonna talk briefly about MAPI. So this is 3 non-exchanging compartment using zero image plus 2 non-zero B value approximately 1K and one of approximately 3K. And so this is the main output of the module I showed you. So it basically have 3 compartments and 2 level model analysis. One is Gaussian. It's like an the isotropic component. The other is an isotropic diffusion comprising intra-neural submodel and also extra-neural. So it's different component. Some people call that restricted diffusion component for intraneural and hinder diffusion for extraneural. So I like this too because it makes sense for neurologists like me, right? Just restricted diffusion or hinder. It makes things simple. So you can see mostly of the cortices is hindered, right? Appear in red, and most of the biometric appear like green something. It's a bit more directional, right? So in the real patient, you can see nothing change over the local glioma. We analyze like this is either diffuse stability demonstrated by NODI, and some tumor has like a restricted diffusion and peritumoral hinder diffusivity. And the necrosis area of the tumor might have the iso diffusivity component at the central area. For MS, if it's not active lesion, they just like a hinder diffusivity over the lesion. But if the lesion active, there might be restricted diffusion. And yeah, for stroke, you can see nicely demonstrated the diffusion. This is stroke. Okay. We try to setting up the protocol over the clinical scanner. You know, when we translate the advanced diffusion on the validation stage to the clinical scan, it's not easy. We try to set up the protocol. You can see a nice gray-white differentiation. This is the FICPF, this is the ODI, this is FISO. You can see iso diffusivity over the ventricle. So we try to set up the protocol. I think this is almost the last one. This is Excalibur and axonal diagram mapping. So for principle, we use 2 non-exchanging compartments, restricted and hinder diffusion. So, but the thing is that it needs rich multi-shell diffusion, time data acquired, maybe a long scan. Yeah, the metric is going to be axonal diameter and density. So this is the work from Dr. Susie Wang. So she analyzed the multiple sclerosis patient compared to control. So you can see larger apparent axonal diameter and increased axonal density in the normal appearing corpus callosum of MS patient. And smaller diameter axons seem to be more vulnerable to axonal injury following demyelination. Yeah, she nicely demonstrated the relation. Other than that, we can furthermore characterize the axon and myelin using imaging G ratio, nicely demonstrated by Frank Yu, one of our colleagues. So he analyzed the white matter and lesion using G ratio diffusion imaging, scan over the connectome scanner. So the G ratio is basically the ratio of the MVF, this is myelin volume fraction, and AVF axonal volume fraction. It's a ratio based on alternation of myelation axonal liquidity relative to health white matter. If the MVF decreased and AVF didn't change, the G ratio increased. If the MVF decreased, AVF decreased, the G ratio is still the same. So this is the clinical subject using G ratio. So you can see the white matter lesion, which calculated as increased G ratio. We interpret that, oh, this might be demyelination rather than axonal damage. In the lower row, you can see the G ratio doesn't change. So there might be mild and axonal damage in this patient. This is how we apply the technique. This is another work from Andrew, our colleague. So he conducted a study like association between CC damage and compared to clinical and also analyze the surface-based homologous interhemicyclic connectivity in MS. So the basic of the connectivity you see diffusion is that you can evaluate the probabilistic of the connectivity between one thing and another thing. For this context, for example, you analyze each of the area of the thalamic subfield, which can connect to the corresponding cortex. You can see the corresponding color, and then the same area that connect together. At that time, we use FSL. So the result is that he found that the SHIC, or surface-based homologous interhemicyclic connectivity, was significantly decreased in memory motor cortex and other particular area on MS patient. And the thing you have to think about is the rescan repeatability of the diffusion image. When you use the advanced thing, you have to think that, oh, this is reproducible. Like that. You have to test on your scanner. Yeah, this is the work from Shirley Fan, one of our colleagues. She demonstrated the reproducibility of the diffusion image. I think this is the last slide. So, okay, fine. Okay. Dr. Chien, the speaker on the first day of the conference, he's my colleague. He used the deep learning for improve the quality of the diffusion imaging with the low resolution, low quality, 6-direction diffusion tensor imaging, and he used his network to improve the image. The rationale is that if the patient get a scan with an old scanner or the same protocol, but we want to use the fancier analysis and maybe frontier analysis, how we use that data, right? Is that usable? So he tried to use the network to improve the data from the real scan and compare with the Gaussian using deep neural network. So it improved a lot, right? Yeah. The resolution and also the quality of the 6-direction scan. So this is all my talk today. I cover the basic diffusion imaging, some of clinical application, and also some of diffusion model, and just touch some of the connectivity and the tractography. So I would like to thank all my colleagues at Sinodad Hospital, Mahidol University. The hospital is just across the river, you know. It is a large hospital. And I would thank our colleague at MGH, and yes, this is my hospital. Thank you so much for your attention.